Welcome to HEAL 6825 Quality and Safety in Healthcare Week 4. And today we're actually talking about fundamentals of patient safety science. A lot of what you see in the literature or on the hospital floors or in clinics is actually solutions to patient safety problems, not the actual science. So, for example, medication reconciliation, there may be a science to it, but it's really a solution. So today we're going to talk about the science for the next couple weeks. What causes error? Um, and usually it's a human factors kind of issue. So I'm not going to go over all of these slides, but I'm going to pull out a couple concepts. Most error, even if you have the best incident reporting system in the world, isn't reported for all of these reasons. Sometimes staff don't see incidents as errors, and this is the definition of an error. It's a preventable adverse event. You can have adverse events that aren't preventable. You've done everything right, and it's just a poor outcome, but not based on any preventable thing. It can be an act of commission, doing something wrong, or an omission, which means failing to do the right thing, that leads to an undesirable outcome. So an adverse event, again, may be an error, but an error is always an adverse event. It could be a near miss too. Types of errors are things like med errors, falls, diagnostic errors. So they're categorized in different areas to help analyze them. What to report, I'm not going to read this slide, and always follow the policy of where you work. But reporting any event is super important, and near misses are also important because they're potential safety issues that maybe we can address down the road. Now, if you didn't cause an error or find one, report it, even if you didn't make it. Some people worry that it's blaming people, but it's all about capturing the error for the patient and for the environment too. Complications can be part of the disease process, or they may have occurred due to error. So, for example, if a patient has a lot of bleeding and dies, it may be worth the hospital's while, or the physician or the nurses, to go back and look at medication doses. If you think something has occurred, the complication due to an error, like a med error or monitoring issue, report it. And again, follow the rules of your institution. So one key concept of error is causality. Did it cause the error? When you're filling out an incident report, you're given a menu of causes, and just pick what you think is right. Further review may reveal different or additional causes. Also, incident reporting systems look at severity, and again, follow your hospital's rules. Sentinel Events is a joint commission term, and it basically means an incident that results in death, permanent harm, or severe temporary harm. And the definitions are there. They're actually based on evidence from the National Quality Forum. And most hospitals, healthcare systems use this list of definitions, even if they're not joint commission. Often systems will use this. So on to the safety science pieces. This is 14 years ago. It doesn't seem possible, but in Indianapolis, there's 3 premature infants that died after getting improper heparin doses. And actually, that was at my institution just after I left, and we were very upset at the errors, of course, but the organization responded very well, and supported all the caregivers. Also in 2006, a laboring mother received the incorrect epidural dose and died. And this is the subject of review in the Smetzer, Leap, Denham, and Decker articles. It had a very different result. And this is a photo of the Wisconsin nurse that was sentenced. And this picture actually haunts me, and really always motivates me to try to help caregivers and patients as much as I can. The very next year, even though the heparin issues were widely publicized, and basically what happened is the Pyxis machines were stocked with the wrong heparin. The nurses assumed that it was the right kind because there was only one sort in there, but it was the wrong concentration. So everybody looked at their heparin, but that very next year in 2007, Dennis Quaid's twins went through the very same thing at Cedars-Sinai Hospital, which is the hospital of the stars. So that raised a lot of questions as to why doesn't information flow better? Why aren't we reviewing our systems? And it's a good way to consider patient safety science, because just actions not based on science probably won't help the situation. So we're going to dig into a little bit of this science. So this is actually a graphic and that shows a perspective of the organization. So what this shows is the caregiver at the bedside, whether it's a pharmacist, a nurse, physician, is at the pointy end of the triangle. And often that's called the sharp point of the organization. That employee balances management's decisions. So, for example, if leadership picked a certain electronic health record, then that affects how care is provided at the sharp end because caregivers have to use it. So there's all kinds of decisions that are made. One is around supply chain, and we've seen that in COVID-19. But basically, that person at the sharp end, I always think of kind of Atlas balancing the world on his shoulders, has to balance all the decisions that were made for him or her. And you add to that evolving and escalating situations, because we know on a healthcare setting, things change all the time. There's interruptions. So it's a challenging scenario. And you hear people talking about the blunt end and the sharp end, and that's what that means. Work complexity basically says that complex organizations fail due to a series of small failures termed latent failures or gaps. And these are things that aren't often seen. So maybe it's a code that people can't see in the electronic health record. Maybe it's a policy or procedure that has never fully been tested. It can be a lot of different things. This work complexity is an important concept. And in the videos this week, Dr. Patricia Ebright talks about work complexity and how nurses and really other healthcare professionals operate in this complex world. And this actually is my favorite slide. It was made by Emily Patterson. She is a researcher at Ohio State, and she's not a nurse. She's a human factors engineer, and she followed a nurse giving medications. She's interested in, the engineering principles. She was amazed because when she followed the nurse got constant interruptions. So you think, you pull out a policy and it says, clean the site if you're giving a shot, all of the steps that you do. She was surprised that all of these other things happen. So if you look at this particular blue slide, everything between these two lines is the actual medication administration process. Everything outside are all the interruptions that the nurse had. Now, I think this is applicable to whatever job you have, really in the world. But it just goes to show that whatever we're deciding from a policy basis from that blunt end goes into an environment like this, and that helps us analyze error. Swiss cheese model, I think you guys have probably seen this. It says gaps line up causing the error, and there's system gaps. And when everything lines up correctly, you have the error. And near misses are really the individual at the front line blocking that last hole or a hole previous to that in the Swiss cheese. That's why it's important to cite that. Now, there's some new information that says we shouldn't look at error like that. And that's the SAFER 2 guidelines. It says we should look at all the interactions, and that's the subject of your reflection discussion this week. So I'll be interested in your thoughts of that. And also look at Dr. Ebright's video that says the invisible work of nurses, because that shows how nurses, and really any healthcare provider, prevents error just through constantly evaluating and trying to figure out what's going on with patients in the environment. Hindsight bias, we've talked a little bit about that. So this little guy wearing all the hats had an error, and he has been juggling lots of different roles, work in the wild. It's, maybe it was a super busy night, maybe it wasn't well staffed, maybe the medication wasn't where it should be. And the next morning, Mr. Administrator comes in and says, well, you should have checked the armband. So we have to make sure, think back to that blue slide, that we take into account the environment in which it occurred. The things that go right, again, the Safety 2 white paper, performance adjustments with resulting variability is necessary. And it could be a transient phenomena. So basically what it says is if you do a review of the incident and maybe the nurse or the physician is distracted because their child last night had an earache and they hadn't slept all night and they're waiting for the doctor to call, you're not going to necessarily replicate that in an action plan. It probably will only exist at that time. So you focus on what goes right. Again, a new way of looking at things. And here is a slide that lays that out. Now, one thing that you always have to think of is human error should be the beginning and not an endpoint of a root cause analysis or an error review. And root cause analysis is the system by which we look at error. And the Smetzer articles will set that out the next week. When somebody says an error is a human error and that's it, to me, that's a fancy way of blaming the human. There's always something that caused the human error. So whenever anybody says it was human error, your answer should be why or what happened, so we can dig a little bit more. And you hear that a lot, even though we've been studying this for quite some time. So yes, most things are human error, but the correct question is, why did it happen? Was it training? Was it, a supply issue? All of those things. And 99.9% of the time, there's one of those issues. And we'll talk about that more in Just Culture. One method that I think is useful in reviewing error, and it's kind of a modified root cause analysis, is the first story, second story. And let's take a case. We have an 81-year-old woman with a history of reflux who underwent an upper endoscopy and a laryngoscopy in an ambulatory surgery center. During the procedure, her vital signs plummeted. She was taken to the hospital, declared brain dead, and taken off the vent. The second story, so that's the first thing, and people might think, well, she was older, her time had come. But when they looked at the issues, she was a high-risk patient, many surgeries. The physician wasn't credentialed to perform the surgeries. They did it as a convenience to the patient. The patient was a celebrity. Staff took selfies. They were distracted, and they missed monitoring alerts. This is all in a CMS report. And if you haven't guessed, you can always find some interesting things in the news. And unfortunately, this was Joan Rivers, and you can read about her case online if you are interested. But if you go back and look at that first story, when you dig in, the initial story isn't always what it seems to be. Again, somebody could write it off and say, her time had come. When people looked at the situation, think of the blue slide, think of the management decisions around credentialing. That physician wasn't even supposed to be there. They found many things to fix. So that is our material for this week. Have a good